All right, good morning, folks. It's 9:30 here at the offices at the Health Quality Council, so we'd like to get started. I want to give a special welcome to those of you joining QI Power Hour for the first time. My name is Deborah Wright, and I'm the Executive Director of Learning and Innovation here at Health Quality Council. QI Power Hour is a free monthly WebEx offering hosted by the Health Quality Council and provides an opportunity for colleagues across healthcare as well as other industries to hear from local and national improvement experts on a variety of quality improvement related topics. Just a reminder that following today's session, a recording of the event will be posted to our HQC website for you to share out with your colleagues who are unable to join us in person today. We also invite you to check out recordings and presentations from past sessions on demand at the address listed on your screen. While you're on our Health Quality Council website, we also invite you to sign up for our distribution list to ensure you're receiving regular invites to all our upcoming QI Power Hour sessions. Over the last number of months, we've been delighted to see how QI Power Hour has continued to spread throughout our province within the provincial healthcare system as well as to those in other organizations in Saskatchewan who have an interest in quality improvement. We've also begun to see spread to other organizations within Canada and even abroad. So again, I want to welcome you all to QI Power Hour. We encourage folks to share their questions and insights during today's session by making use of the chat function. You can access the chat function by clicking the message bubble at the bottom of your screen. We encourage you to share your questions, comments, and ideas throughout the presentation today, and we'll have some time dedicated for Q&A at the end of the presentation. Please send your questions to all participants so we can all join in on the discussion. Let's take a moment to practice using this function by typing in the chat the name of the organization you're joining from today. I saw some come up. Perfect. Okay, so it looks like we found it. All right. So we also encourage you to interact with our speaker today by using the feedback function. You can access the feedback function under the participant menu on the right-hand side of your screen. You can select the megaphone icon and then use the yes and no feedback items in response to Dr. Hayes' questions this morning. And finally, we also invite you to log into your Twitter account and tweet out during the session to share your learnings. You can use the hashtag QI Power Hour and the handle HQCSask for today's session. And we've also included Dr. Hayes' Twitter handles as well, so you can also use @DrChrisHayes or @HighAdoptQI. All right, so now I'd like to introduce our guest speaker for today. Dr. Hayes is the Chief Medical Information Officer at St. Joseph's Healthcare Hamilton and an Associate Professor at McMaster University. He is a 2013-14 Canadian Harkness IHI Fellow in Healthcare Policy and Practice. Formerly, Dr. Hayes was the Medical Director of Quality and Performance at St. Mike's Hospital in Toronto and the Medical Officer for the Canadian Patient Safety Institute. He is recognized as a leader in patient safety and quality improvement, working with regional, national, and international organizations, and has received multiple distinctions and awards. With that, I'll welcome Dr. Chris Hayes to start his presentation.
Thanks so much, Deborah Jane, and just hoping people can hear me. It is a pleasure to join you today, and it's just on the heels of actually being in Saskatoon with the CQIP capstone group and having the pleasure of seeing the great work that's being done in Saskatchewan and with the support of the Health Quality Council. It's quite impressive, and so I may be talking to a more mature audience today because I definitely felt that while I was there, but despite maturity, I think there's some of these issues are going to be relevant independent of where you work, and hopefully some of the comments and tools that I'm going to present will resonate with you. So really what I want to talk about is, you know, we're probably all doing QI, and as most know, and certainly if you read the literature, the success rate and, you know, what is success, and we'll talk about that, but if success was to equal that a year from now you've you've got the same goals, you're achieving the same goals which, hit your aim statement target, then that would be a good success rate. And so that rate is not super high for lots of reasons, because change is not easy, but for reasons that I think are avoidable and addressable in increasing that rate, and that's what I want to talk about today. And just to mention why the three organizations are in that first slide. So a lot of this, what I'm going to talk today, was my research project while I was doing my Harkness Fellowship, which was co-funded by the Canadian Foundation for Healthcare Improvement and the hosts, which was the Commonwealth Fund. And then I had the pleasure of sitting, although we didn't sit much, but spending the year at the Institute for Healthcare Improvement, then in Cambridge, now in Boston, where I really had time to think about this issue while I escaped my day-to-day job at the time, which was, well, partly being a physician in the ICU, but as my administrative role was, how do you implement quality improvement across an organization that is successful, that sticks, and that people actually enjoy doing and contributing to a positive culture. So that's what we'll talk about today, and we'll talk about what the term we've sort of named this is highly adoptable improvement. So to do that, I want to sort of get a sense of who's in the audience and whether they share the same experiences that I and others have, and use your participant feedback part to answer yes or no, and put in the chat section any comments related to this set of questions. So if you are an improver, have you heard this? If you are a recipient of change, have you said this? And the statements that I want to see if you reply yes to are hearing from end users, clinicians, whomever was the impact of change. We don't have time for this. Too much change is happening. We don't understand why we have to do this. This doesn't make sense, and this doesn't match our workflow. So if you can participate with me for a bit there and tell me if you have heard this, thought it, or said it as it relates to quality improvement or change. And I think I can check feedback here, so and I'll let you know. Oh, I'm good. I like that feature that somebody's putting laughter down, which is great. Okay, so we have 53 attendees. Let's see how many votes we get here. Oh, and I see the chat line going as well. Yes, and people are voting. Okay, so I always like to see somebody says, oh no, we don't have this issue, because then I come and visit you and figure out how you're doing it. But so on the feedback results from the yes, it's 11 people said yes, and 1 person said laughter. So that's great. And then the chat line, everybody says yes. Okay, great. So we're not alone. You are experiencing the same things that I and many others do. And then, ask again. So either second question, really, do you have this sort of output where, your project, you put all this effort into a project and it works for a while, but you sort of move, as you move away to the next thing, or 3 months, 6 months, 9 months down the road, the results are waning and they're not really sustained. And as an approach to try and boost up the process or outcome measures, you implement reminders, or you provide compliance data on, comparing one unit or one department or one area to another as a mechanism of reminding people to, keep up the hard work. So again, see if you can answer yes to that. Put some comments in the chat line. And there, yep. So we're getting exactly the same. Now sometimes, yep, and that's, it probably is sometimes. I mean, this would, if we didn't sustain, if we never got any successful results, we might not want to keep doing this. So you're right that this is not, it does happen, but fortunately it doesn't happen all the time, and some things absolutely do stick. So great. Okay, so I just wanted to start with that we're all coming from the same place, that people seem overwhelmed with change, or the fit of that change within their work environment, and although we move forward and implement, those results are not so easy to stick. So great, and one of the reasons probably why is, and the one that I sort of pursued the most was, maybe it's because we're just doing a million things. And so this list, which is a bit Ontario-centric in some of the descriptions, but if I filled up this slide, I could keep filling it up and filling it up with other initiatives that either people have selected to do as in an effort to improve healthcare delivery, or they've been told to do, or has mandated to do, whether it's part of legislation, regulation, or accreditation. And so the list is big, and so my experience was, when I was sort of trying to lead this from an organizational perspective, I felt like my to-do list was jam full, and when things are jammed full, can you do it the way that, when you've got lots of times, you can do things better, more methodically, take more time, apply more detail. When your list is full, you tend to shortcut those approaches because you've got a performance gap that you need to address. And this is certainly what I was feeling, that we don't seem to be doing QI the way we used to do it. We're now sort of just doing it, putting it in, getting it in there and moving on to the next thing for the sake of trying to get something off the to-do list. And then the question of whether it sticks is, we've all just described. So this is, it's not surprising that this is what we hear when this is what we're doing. And so my big drive to sort of do the Harkness Fellowship and study this was because I felt that in an effort to improve healthcare, are we making it harder to provide care or manage care? And if the answer is yes, then we have a problem, because how are we going to close all those gaps and meet all of those aim statements if we're making it harder through change? And so if this is true, there needs to be other approaches out there, because others seem to be succeeding. Some of the high-performing healthcare centers that we've all learned and read about. So what are they doing? And so that sort of sparked my interest in learning from them and from the literature. And so one of the things is harder. So harder can be defined by increased workload or lower capacity. And by workload, I mean cognitive, like the mental demand, the physical demand, or just the temporal demand. And so in any environment, there's going to be a baseline workload. And, whatever measurement tool, or there isn't a standard measurement tool, but whatever, it's in that environment. And then you're going to come in and do something differently. You're going to implement a new standard, a new process, whatever it is, in order to achieve a higher state of performance and meet an aim statement within your QI project charter. And this probably increases workload during that period, because you're interacting in the environment, you're manipulating it, you're educating through lunch and learns or whatever other mechanisms. And so people see that that's workload, and that probably is okay, because maybe you need that increased workload so people recognize that you're expecting change. The question is, what is life like afterwards? And really there's three options. There's the workload is not changed, or perhaps you've increased workload or reduced capacity through your change initiative. Or you were lucky, or you designed this way, you've reduced workload or generated capacity. And the answer is, how do you know which one you're going down? Well, most people don't know, because we don't measure workload associated with change in a habitual method. Lots of people do, but I would say the majority of people are not. So that's graphically presented through one project, but we're not doing one project at a time, and there's not one change initiative going on at a time. And even this sort of cumulative impact is too clean, because we're often doing multiple things right on top of each other. But let's say, for argument, that every new change initiative came with an incremental bit of workload, then we will go continuously down the increased workload path, which is unsustainable. You can't just keep adding and then expecting people to be able to do that work in the way it needs to be done in order to achieve the goal. And then hopefully, obviously the ideal state would be to say every time we interact with or manipulate the environments for which we're seeking change in, that we actually reduce the workload and produce a more and more ideal state. There are very, very, very few examples of people going purposely down the green path. So that's workload, which, is sort of more of a machine-like construct. How much can you push this machine before it gives or underperforms? But people aren't machines because they have brains, and their brains will make choices and put value on things that are presented to them in a term that I call perceived value. And we seek meaning, develop feeling towards either choices we have in our lives, because this has nothing to do with healthcare, this perceived value, or options that are presented to us. And so as far as it relates to QI, perceived value is the willingness or readiness of individuals to adopt change when they believe the outcome of the change will be of value to them or things of importance to them, like their patients, like their colleagues, like their organization, like their career. And this is a marketing term, so it really has nothing to do with healthcare. This is the cognitive process or subconscious process that people go through when they decide whether they're going to buy something, make a decision, adopt change. And it has three components to it: emotional, practical, and logical. And so the emotional part would be that feeling you get, when the thing you want, the Ferrari, the iPhone Mega or whatever it's called now, that seems like it's huge. I mean, why is it not just an iPad? I don't get it. But it's big and people want it and they get all excited. And the practical thing is you already have, can I afford this? Do I need this? What's the function for it? Does it make? And then the logical one would be, I actually only need it to make phone calls. I already have a phone. So this is the process that you're going through to place perceived value on an option. And I'm sure it doesn't surprise people that emotional trumps practical and logical by a lot. And in fact, you can make poor decisions on the emotional state over the practical and logical. And the example I use is, this is why you shouldn't watch TV at 2 a.m. in the morning, because you're going to end up buying something from some infomercial that's tugging against your emotional heartstrings because you see value in it, but really there's no practicality or logic to, buying some of these, home exercise equipment that make you look like the guy on TV or woman, and there's no way that's going to happen. But they've got us emotionally. So emotion has a big factor, and so as it relates to, and here's an example of, maybe doing medication reconciliation as an example. If you can see that will save lives, then it's going to get at your emotions. Then you say, well, I can see myself doing that new practice, and that new process makes sense. If I do this, then we will save lives, and I can do it. So this is how we generate perceived value. And so these two constructs, workload and perceived value, were part of the hypothesis that I went to study, which was if change initiatives were designed such that they did not add additional workload and have high perceived value, then they're more likely to be adopted, cause less workplace burden, and achieve the intended outcomes. And so on the graph here, you've got increasing perceived value on the left and increasing workload on the right, and increased sustainable adoption, meaning people are willing to and able to do the new work sustainably. And if that's the case, you get more adoptability and hopefully then more success. And so the idea is, well, if this is true, then you should design all change initiatives for the top left quadrant. If you design them for the bottom right, you're going to be just pulling out sticks and constantly putting attention on this to try and keep it afloat, whereas people seek simplicity and seek value in their lives, so design for it as much as you can. Nice hypothesis. How do you do this? So that's what we sought out to choose. And so looking at the literature, talking to a whole bunch of experts in QI, visiting and studying a bunch of high-performing healthcare centers and then bringing an expert panel together to sort of describe this, we came up with the Highly Adoptable Improvement model. And so in the middle is sort of the recipients of change, those people that are going to have to do something different in order for the goal to be achieved. Often this is frontline providers and managers. And in that environment, there's an interaction between those constructs we talked about, perceived value, workload, and capacity. And so they react with each other, because if you have high perceived value, if you feel something is really something that's important, you want to do it, then you'll underestimate the workload or overestimate the capacity. And that works fine for a while if you have the workload and capacity. But, this is why, in March, our New Year's resolutions, if they're challenging, we don't achieve them. And there's really only one way to deal with that situation. You either achieve it to get rid of this disconnect between what you think you should be doing and what you're not doing, which is cognitive dissonance, or you devalue it. I don't really need to, I'm only down to half a pack of cigarettes a day and my friend smokes 3 packs. So some way of devaluing so that you're not dealt with this issue. So that's going on in the environment. The flip side is if there's no perceived value, then workload and capacity, or the workload is estimated, and people are just like, I don't want to do I won't do anything in order to achieve that goal because I don't think the goal is important. So these things interact, and then you're going to come in with your quality improvement initiative and do something to this environment in 2 ways, and it looks like the arrows are a bit blurry there. So one way is through the intervention design, like what are you actually asking people to do? What are the tasks? What does it look like? How do they do it? How do they know how to do it? Do they have the resources? All those things. And then the second one is the implementation strategy. How are you asking people to do it? How are you involving them? How are you listening to them? How are you having them part of the process? And so the model presents 2 dichotomous outcomes. Okay, so the arrow should be, so this should be increased workload, decreased value, and decreased capacity. So you're increasing the workload and it's a low perceived value. Then the literature is very clear. This induces burnout, change fatigue, cynicism, makes people do workarounds, and increases their likelihood of error. And since they can't actually do the tasks because they don't want to or can't do, you're less likely to achieve your intended outcomes. And as a result, this has negative feedback on those people because they're saying, well, wait a minute, you told me that this would save lives or improve whatever. We don't see that, and this works harder for us. We don't like this. We don't want to do this again. Please don't come back with your next quality improvement initiative. It builds resistance into that environment. But perhaps, and these are now, the green is meant to say decrease workload and high perceived value or augmented capacity. It's also clear from the literature that this increases the likelihood that people will do that task repetitively and sustainably, and if that leads to a beneficial outcome, you're more likely to achieve that intended outcome. And this has positive feedback on the recipients of change, the providers, whoever it is, because they say, wow, look what we achieved together, and you know what, it wasn't that hard. I like this quality improvement stuff. Let's do it again. And I will tell you that many of the organizations that I studied, they live in the green. People are very willing to participate because they see the benefit and they don't feel overburdened by it. And their QI culture is therefore high, and their resistance to change is lower. I mean, I'm not saying it's 0, but those people that, when we tested this model or reapplied it back, it made sense in those organizations which you would say, that there are case studies written about, Virginia Mason, Theta Care, Kaiser Permanente, Cincinnati Children's, Bellin, Geisinger, all these places seem to be doing change in a different way. So nice model, got some nice colors and arrows, but what do you do about this? Like, great, what are the factors? So we identified 72 factors in the literature that impacted adoption or perceived value, not QI success, and only focused on the things that were related to the intervention, design, for the most part, not the context that you're in. So we didn't address leadership or data infrastructures that are very important for QI success, But you can have all of those things and still create an intervention that overburdens people. So we focused on really the adoption piece, and then we went through the list and decided which ones most applied to QI and were most actionable, and then we took the remainder and thematically coupled them into 6 things. And I don't think these are a surprise, and I can't tell you yet which is the most important one. I need psychometric data properties to be able to do that, but I will tell you that the first one's the most important. So end user participation. The more you involve the people that are ultimately going to have to do this work, 2 things will happen. You'll get a greater appreciation of their workflow and how things will fit, and you'll get greater buy-in and an intervention that actually works by having them involved. So the more they're involved at every stage of change, the more likely you are to generate perceived value and, you know, a intervention that works for them, and which is likely less workload. The second one is alignment and planning, and this is again more of an implementation strategy. If you think this initiative is so important, are you willing to make space for it? Are you going to stop other competing priorities? Are you going to communicate that this is coming so people have time to prepare? It's going to be part of a plan that's visible and understood and hopefully shared, rather than, you know what, we've identified a gap, you know, 1 month before our accreditation visit, and we've got to close this. That has a very different perception at the front line when it doesn't appear to be aligned and planned. Resource availability. Do you know what it takes from a training, equipment, time, and personnel perspective for this initiative to work, and are you going to make those available? And now, obviously, resources are often costly and timely, but that doesn't mean that they're not required. And you may not be able to apply them all, but at least if you know and be honest about, look, we don't think we can do this right now, but we're going to try our best, at least recognizing builds perceived value and makes it more likely to work. And then there's workload. So again, cognitive, physical, and time. How much is associated with the intervention? Are you measuring it, you know, both objectively and subjectively, which I'll talk about in a second. Complexity. Humans want simplicity and low complexity. They want simple things that achieve a goal. How complex is the intervention? Could it be simpler? Could maybe humans not be required to do it at all? And then efficacy or perceived efficacy, meaning what's the degree of belief and evidence that if people do this intervention, that it will lead to the outcome. And there's 2 sides to this. One is, you know, I believe that if I do apply evidence, there's evidence to say that if I do something differently, I can reduce the incidence of pneumonia on people on ventilators. Yep, I believe that. Then do I believe that the way you're asking me to do that, will also achieve those goals? So it's not just the evidence, it's the way you're deciding to implement that evidence, and both are important to generating this sense of efficacy that this will work, which really speaks to the logical component of perceived value. So these are the 6 factors, and what we produced was, in the toolkit, was a set of statements around each of these themes or elements that range from highly adoptable on the right to high risk on the left. And we didn't want to say low adoptable because it might work. I mean, maybe you don't test workload or you don't involve end users at all and it might work, but we believe that that would increase your risk of lack of adoption. And so 2 examples here, you know, you've involved staff or physicians continuously at the designing, piloting, revising, you know, spreading stages, and you're constantly looking for their feedback and addressing it, versus, you know, this intervention has not been designed with or tested with end users, higher risk. And then from workload, I mean, essentially the highly adoptable statement says, we've tested this, we understand the workload demands, and actually we think it's going to make their lives easier, or we know it's going to make their lives easier, or where moderate risk would be, we have attempted to estimate the additional workload, and we believe that they can just adopt it, like it's an extra 20 minutes, who doesn't have 20 minutes. So that's more moderate risk, because incremental work, there's no space for the most part. So we had, again, a set of these for each of the 6 elements, and then we pointed people to mostly existing tools. We didn't look for new tools. We just looked for ones that were there. And the one that I like using, I think is quite valuable, is a subjective workload tool called the Task Load Index that's been validated and used by NASA for 20-odd years. Essentially, they give this to the people that are going to be doing the new tasks and ask them, how mentally demanding was it? How physically demanding? Were you hurried? Did you feel like you succeeded? How much effort did you have to put in? And my favorite, how insecure, discouraged, irritated, stressed, and annoyed were you? If people answer very high to these, there's a stronger likelihood that your initiative will fail from an adaptability perspective. So that's one tool, that and a stopwatch or your iPhone to measure how long does this task take. And yes, here's the link. Oh, perfect. And then asking some sort of using lean, and not lean to take resources or wasted resources out of the environment, but using lean to take wasted time and steps out of a process. So does it need all the proposed steps? Could steps be simplified? Could necessary equipment and technology be provided to reduce the workload associated with steps? Or if there is workload, could other staff, providers, and patients and families be involved to distribute the workload? So these are looking for non-value-added time and tasks and trying to remove them in order to decrease the associated workload. So, and there's more tools, or points for more tools in the toolkit, which is all available on that highlyadoptableqi.com website. So how do I say to use this? So hopefully you download the toolkit, and I'm trying to make it more interactive, but I don't have time. I haven't had time to work on it, but at least all the tools are there. How do I suggest that you use a highly adoptable way? Well, use this checklist. So use the assessment guide in planning, designing, and during the intervention and testing phase of your project. So iteratively go back to that, asking yourself those questions around the 6 themes. And if you identify that something is moderate risk or high risk, use strategies within the toolkit to try and drive it towards high adoptability. Choose interventions with a demonstrated degree of belief. So, and this doesn't mean they need randomized controlled trials, but some evidence that the way you've designed it is going to work. Did it work in other organizations that are similar to you? And are they using the same methods? But then you still have to measure, doesn't mean it will fit 100%, but at least don't say, come up with some completely different way of doing something, which is fine. That's called innovation. And innovation is a great thing, and I think we need more of it, but you don't implement innovation. You test it at small scale to prove that it works before you make people do it. Make workload a consistent balance measure. So hopefully you all know about structure, process, outcome, and balancing measures. Most balancing measures are sort of the negative effects of the intervention. Well, this should now always be workload, if not provider satisfaction, happiness, joy, or perceived value should probably be a balance measure too. Measure workload objectively and subjectively with, you could use the NASA tool, there are others. Work to simplify the intervention. Don't take it at face value, ask yourself exactly, can I get rid of the steps and still achieve the goal? And then work at the same time to remove wasted work. And I think if you're going to go in and tinker with an environment to try and make it better, use it as an opportunity to say, is there anything that you do that is of no value? Because maybe we could clean that up at the same time as we're adding something that may have incremental workload. And so this is sort of what we call the highly adoptable checklist to try and use this. So now I'm going to stop talking, but and hopefully there's some time for questions. I do think that healthcare improvement efforts they are increasing workload and therefore often fail as a result. You've really choosing the right interventions and the right implementation strategy is essential. Hopefully you will find the highly adoptable improvement model and guide and toolkit helps focusing on the impact of change and find it useful and usable. But we need more efforts on this. This needs to go not only at the organization and the QI team level, but all the way up to the the Ministry of Health to say, should we be throwing all these initiatives at people? Should we be clearing up space? Do we understand that these things are going to work? And I think the same principles need to be way up the line so that we get, fewer coordinated, more, better resource initiatives that work rather than just saying everybody achieve this and you make very small gain that we expect more and patients expect more. So thank you. I forgot about this one. So yeah, we know caring for patients is hard, although very rewarding. Change is definitely hard, but let's stop making it harder. I think it's our obligation if we want more progressive, accelerated, and sustained improvements in healthcare. So again, there is my email and Twitter handles and the website for which everything I talked about is there. So with that, I would like to turn it over to you. Hopefully we can get some questions going. Thank you.
Great. Thank you, Dr. Hayes, for your presentation. And just want to remind folks that we have the chat function set up. If you have questions after hearing the presentation today, that we have time to continue to engage Dr. Hayes and learn more. We've also uploaded the link to his website and toolkit on the Highly Adoptable website. So that's great as well. So, yeah, I'll just pause to see, do we have any questions from folks today?
This is the WebEx radio silence. Yeah. I mean, so one of the questions that comes up, I didn't see anything. Did something come up below there? Oh, yes. So the question from Jody is, can you speak to your experience, or do you have any tips on how we let go of old processes? I think this is a challenging thing. So I 100% agree. So Maureen Bisignano from IHI calls that process X-Novation. So innovation is adding new things or coming up with new ideas and adding them, and X-Novation is getting rid of things. And, you know, we don't do enough of it. Like, we don't have enough resources, you know, in healthcare. We're a resource deficit, and I'm not saying money, but in whatever sense, we always feel like we need more to achieve, yet we don't let go of things that don't work. And so there absolutely needs to be a mechanism, and I think you can make it as a design principle. I mean, I guess I'm calling it go in and look for wasted work, but you could have X-Novation rounds, right, and go around and say, you know, what, and really this was the process in what was called, which was done in Saskatchewan, the Releasing Time to Care initiative and Transforming Care at the Bedside, the American version, and it went through and said, look, what's getting in the way of you providing patient-facing time so that you can, you know, feel like you're getting rewarded by, you know, actually completing the tasks and meeting the needs of the patient. And they went through and said, well, and you know, in fact, in their study, they showed what percentage, like documentation is a huge one. And I think we need like a, you know, absolute rethink of what the purpose of documentation is, because if nobody reads it and it's of no clinical value, then it's just a historical record for others to use, like lawyers, and that shouldn't be the purpose. So there's a lot of ways we can go in. So I do think, as far as my experience, oh, you're saying it, on how we let go of it. Yeah, so that would be, it is definitely a challenge. You've got to make it a, you know, and again, use the opportunity. If you're interacting with people because of a new initiative, use it as an opportunity to say, what can we take away? What can we take away? What can we take away? And then obviously your organization has to be okay with, you know, you going in talking about, you know, let's say a MedRec initiative, but at the same time gaining feedback on what's not working around nursing communication. I mean, there's going to be some territorial issues there, but they get in the way, but, you know, you've got to come up with a way to say, you know, we're all looking for a better efficiency. Question from Adrian is, I'm curious about your thoughts on how to spread a project across a province versus a smaller center or centers. Yes, so spread. So I got a separate talk on spread, and I do a lot of sort of spread work with the Canadian Foundation for Healthcare Improvement, which, you know, is really, I would say they're a spread organization. So first thing is, if you look at the traditional description of a QI journey, you know, it's identify a need, understand the current state, develop a change theory, test that theory through, you know, iterative tests of change and PDSA cycles, find the ones that work, implement it, sustain it, and spread it. Well, I actually think that spread and sustainability are part of your design theory. They're being spoken to in the wrong place. So if you want to spread something, you have to start designing it as spread ready or spread capable. And I think, you know, some of the tools in the model do that, because if it's simple, people will want, and if it's simple and valuable, people will want to do it. So if you want to then spread from across a province, obviously you got to prove to people that it's doable and that it works, and then partner with the right people to spread it. And we are spreading. In fact, we're spreading an initiative in Saskatchewan on family doctors getting access to specialists. I also think that you're adopting like the COPD Inspired initiative, which is spreading across the country quite quickly. So a different talk, but it's got to be something that's spreadable, which means it's got to work reliably in the environment. And reliably also means that it doesn't require you. So if you're working on the initiative, you are able to completely remove yourself from that environment, and it still works. Because otherwise, there's this constant resource required, which will make it difficult to spread. So I actually checked the NASA. So I don't have a link in there. So I'm going to send the link. Let's see if I can. So I don't know the answer to will we receive the presentation? Do you share it there, Jane?
Yes, it'll be made available on the HQC website. We're recording this, so along with the recording, the PowerPoint will be available. For sure.
Yeah. So the NASA TLX actually has it has an app to it now. Like they've become quite. And what I'm gonna do is make sure I've got the get the website here, and I can post it. There it is. So yeah, because I looked on and realized for some reason I must have been tinkering and didn't. Okay, send to all participants. So it's actually, I could have probably remembered it. It's nasatlx.com. So that's where it is. And there's actually more to that. There's more to the TLX score than just going through asking people to fill out that checklist. There's actually, because they're not mutually exclusive items. Like if something's mentally demanding, it might frustrate you. So which of those is driving? So there's another stage you go through to try and isolate which of those is driving the very high subjective workload factors, and allow you to focus more on those initiatives, those interventions. Yeah, so nasatlx.com, you can download the iPhone app, you can use a computer one, or you can just use the paper one. You know, they're all effective, but yeah, there it is.
So, Chris, it looks like we have a couple more questions that have come in. So I do want to kind of flag what we do have from Sam is a question around how do we best manage change fatigue as a result of many failed QI projects among teams. I wonder if you have some thoughts on that.
Yeah, so again, that in the model that shows this, you know, the feedback arrows, the red feedback arrows, depending on how many of those initiatives you've done, you've built a trench of resistance and change fatigue and change cynicism. So how do you get yourself out of that? In my opinion, there's only one way. You have to design something that will succeed. It's the only way, because otherwise you're perpetuating the same beliefs. So that might mean, and this is the hard part of saying, look, we need to do this, right? We're being told to do this. This is a bigger gap, but it's complex, it's difficult, we don't really understand how to do it, not sure that we can make it less workload, and then you're like, okay, but this environment is a tough one. Pick something that you think will work and celebrate its success, make them feel like they're in the green, and chip away at that, resistance shield. And unfortunately, it's the only way that will work, because otherwise you will reaffirm their belief that this is all for some other purpose and it doesn't work and all it does is burden us. So that's hard. And so the question that maybe it is in there, so I'll just answer it. is this is actually harder, more work for QI people and change agents. So that, because the work, it's a lot easier to just throw a checklist into an environment that may or may not work, that people may or may not fill out, and then remind people to fill it out and get like a 2% improvement for those that use it. That it's easier. It's not rewarding, but it's easier to do that than use a highly adoptable improvement approach. But the issue then becomes that my beliefs, and I can't prove it, but based on the evidence that supports the model, I would say that what happens then is you spend more time getting it right, and therefore over time you spend less time trying to fix all those initiatives that didn't work, and you free up time to be innovative and to take on more tasks, and then what becomes easier for you is the adoption part and the cycle time on the project, but the time to design is more. But that's, in my opinion, that's the way it should be. Okay, we got quite a few more here. Yep.
I can bring the next one forward. We have one that's sort of saying, knowing that we want to avoid more, how do we find the balance between identifying change initiatives that are strategic in focus, yet still are kind of honored or emerging from the point of care?
Yeah. So if you are in a, I'll be honest, a lot of environments don't have anything emerge from the point of care staff, right? They're just constantly on those that, the things that they feel they need to do from a strategic perspective or an external perspective. And, that doesn't help QI culture when you're not responding to the needs of the organization. But let's face facts. There's a lot of those things that are strategic or high level or external. So the importance here is to at least try some, whatever proportion of things that you look like you're addressing that are coming from the frontline perspectives of their needs. And then the other part is to turn those strategic initiatives into perceived value initiatives. Well, what is it you're saying? So, and the example that, I don't know if this came up at CQIP or, because I also taught to the Ideas group last week in Toronto, is, you want to reduce length of stay, and there's terms like beyond expected length of stay. So your patient should only be here for 4 days for community-acquired pneumonia, but they're staying for 7. We want to reduce this in an effort to, increase hospital throughput. I wouldn't be surprised if the clinicians that you shared that with said, well, my patients stay 7 days because they're sicker, and I provide better care, and yours is a number, and I don't care about it. There's no perceived value, right? But you could flip that and say, the evidence would say that every incremental day in a hospital increases your risk of infection, and wouldn't it be, if we could do something to reduce anybody's chance of infection, wouldn't that be a good thing? Most people answer yes. Okay, so one of the ways, so you're incrementally working and going to the core value before you just say that the value is, getting your emerged wait times down. Like what's the value behind that? Why? How do you get at your stakeholders' perceived personal, emotional value? And work from that point onwards, and then don't make the next statement, okay, great, now that I've, hooked you, you're going to do this complex intervention. You've got to go through the process of, but yes, you're right. I mean, again, I said there's a lot of work that needs to be done at the strategic and external level to stop firing a hose at us and let us actually address issues that we think are of value coming from the work that we do. And then also align those, like, there's a lack of alignment between government, accreditation, High, and perhaps even health quality councils, depending on where you work. And they all want better, but better can't come, through a flood. It's got to come through a controlled trickle. If I haven't used that analogy before. Curious about your thoughts about how to spread. Okay, we saw that one.
I do have one here, Chris, and it's, can you speak to your experience, or do you have any tips on how to let go of old processes as we're continuing to try to improve?
Yeah, so again, I think that's the one. Didn't I answer that? That's the one where you could use, I think you can use a lot of the tactics in releasing time to care or transforming care at the bedside or TCAB. There's a lot of tools in there that, you know, because you could just make that an initiative, right? So rather than saying, I'm going to implement X and at the same time make the intervention as least workload and as least complex as possible, and at that same time ask what can you get rid of, to just make an initiative on what you can get rid of. I mean, and again, not because lean, if lean comes with a way to get rid of resources to save money, then it will be perceived as another four-letter word. But if you use it to say, look, your day is tough, and if things are getting in your way that have no value, we should be getting rid of those things. So let's come up with a list, and who do you work with? You work with the front line. You actively see how you can remove those things, and they see the value in that type of work. So that's the approach I would take. Okay, I think I've got a question from James on.
Yes.
Yeah, good question. How do you empirically test your model? So, yeah, it's hard because it's sort of, you know, it's one of those things, you know, how do you test a mindset and show that it's demonstrably, you know, demonstrably impacts an outcome. So it's hard. What my plan is to do is, so I teach this in the IDEAS program in Ontario, which is somewhat similar to the CQIP. I think CQIP's quite a bit more robust. But you know what, they start using it, and so they when I go to their final events, they're showing me the use of you know, how they went in and used the NASA TLX score or used the assessment guide, and it changed their intervention. So I either could look at, you know, intervention deltas. I could look at, you know, I could try and randomize, like have groups that aren't exposed versus groups that are, groups that didn't use it versus groups that did, and then measure, you know, sort of did you know, perceived value workload measures, and then perhaps you know, to what degree did it stick. But it's certainly not easy. It's hard to measure things like this, but when I have time, I'm definitely committed. And question 2 was, how do you think the use of stopwatches will be perceived? Yes, exactly. So yeah, so you've got to really explain why you're doing this, because people see, I mean, they've learned this, right? They've learned that if you're coming in, or you put in a camera somewhere, or you start watching them, or you observe them and you write things down, that you're looking for opportunities where they are not performing up to your or some expected standard. And so you just have to say, we want to see all the stuff that gets in your way. And we want to see how long it takes you to do this task, right? Because if it takes too long, then you can't ask you to do it. You know, they might be a bit hesitant at first, but you know, I described a project I worked on at Virginia Mason where they sent somebody in to do sort of PDSA #1, testing the theory of this new initiative, and they said it hit 7 minutes, so they didn't actually see them observing it. They just knew that they were in there, and they were just saying, you know, come out and tell us how it went. But in the meantime, we were timing it, and they said it's too long. It's too long. They're not going to be able to do that. So let's go back and think, what are the essential elements here? So yeah, I don't, you know, always tell people what you're doing, why you're doing it, and have them, you know, see that there's value in people, you know, looking out for their best interests, not looking to see whether they're performing well or not.
Great. Well, thank you so much, Chris, for taking the time to not only present to us the information that you've shared, but also taking the time to respond to the questions that have come through. And thanks to each of you for bringing forward your questions. And if you have further questions beyond this call today, Dr. Hayes has provided you with his email on the website, so you can certainly reach out to him and continue a dialogue if you so wish. So with that, I think what we'll do is just to close out the call, and we'd like to invite you to join us for the next QI Power Hour session on Friday, October 5th. We will have a panel of speakers from Health Quality Council and the Saskatchewan Health Authority sharing key insights about the work and learnings over the past 6 years with the ED Waits and Patient Flow Initiative. We look forward to your feedback on today's session, and you can provide that feedback by completing the survey that will launch as you close out of the WebEx. And with that, we look forward to connecting again in October. Take care and have a good day.